Thank you, Dr. Wolf. Some of you I may have spoken to on the phone. We're always open for consults at Children's. So today I'm very happy to be talking to you about something that I got very interested in. Throughout our outpatient consultations, our inpatient consultations, we started to realize that there is an area and a gap of knowledge with newborn hypertension. Should you take a blood pressure? If you do, what do I do with it? What's high? When should I treat? So I appreciate this opportunity to give this talk. And thank you for doing the yellow forms. I appreciate it. So let's first review what is the BP knowledge nationally in pediatric healthcare. The first study was published in 1999 by Arafat in Pediatrics. And what he found is that less than half of practitioners, this includes attendings, residents, nurses, were not familiar with the NHLBI Task Force guidelines. NHLBI is the National Heart, Lung, Blood Institute. There is a program task force called the National High Blood Pressure Education Program, or the NHPEP, which comes out with task force guidelines. Their initial task force guidelines were not known in 42% of attendings, 44% of residents, and 50% of nurses. This is at a tertiary care institution in Michigan. Later, a retrospective review was done by Hansen, and this was published in JAMA more recently in 2007. What he did is he looked at 14,000 records of pediatric children and adolescents outside of Case Western for all of their satellite clinics, their satellite ERs, and wanted to know if blood pressure records were indicating that hypertension was accurately diagnosed. What he found is that out of 14,000 children, 500 children were accurately diagnosed. Again, now in the New York area, Bonaparte and Flynn wrote an article in 2009. So this is the most recent article. And again, all this is in pediatric patients. No one has ever looked at newborns. And he found that 40% of pediatricians felt uncomfortable evaluating and treating. And only 7% of those pediatricians and about 300 people in the New York area out of the Einstein group routinely started antihypertensive medications on their own. So this is the area and gap of knowledge that I sought to seek and to see what is our feelings toward and comfort toward newborn blood pressures. So the objectives of my talk, and I realize I'm before lunch, so it's a very tenuous time. First, we're going to review the AAP policy recommendations for blood pressure assessment in newborns. We're going to review those task force guidelines that I alluded to on the earlier slide, and these are from the National High Blood Pressure Education Program, which come from the NHLBI. We'll review the newborn populations that you may see that are at risk that should get a blood pressure. We'll review the tips for getting the best one that you can. We'll define what is hypertension, and then we'll understand medical management options and recommendations. So let's start with the clinical case. So a 12-week-old girl comes to you. She's a former 28, 6, and 7-week gestational infant. She's corrected to 41 weeks. She presents to your office for the first time after coming out of the NICU. And the parents are scared. They've gone through a lot. They're just happy to get out of the NICU, and this is your first visit. What you can glean from the information is that the birth weight was low, 700 grams. She was born premature, secondary to maternal preeclampsia. Her mother had appropriate care. She came to one of our tertiary care centers. She took multivitamins, did folic acid, all of her ultrasounds were great. She received antenatal steroids prior to the baby's birth. And the baby was born, has an umbilical arc line that's placed. She was intubated for the first week, transitions over to CPAP after getting surfactant, and then she weans off nasal cannula at 38 weeks of gestation. So as we know, 40 weeks is full term. She also has a PDA, which is not uncommon in our population. She gets 1 course of indomethacin. There's no IVH in this baby, and she was normotensive the whole time in the NICU stay. There's no hypertension in the family. So, should you even check a BP in this infant? So my approach is to first, let's review the Bright Futures guidelines that all of you I know are well aware of for the AAP policy recommendations. So I forgot to mention some of my slides might have little minor tweaks from what you have in the syllabus. So the recommendations currently if you can see here with the stars, those are risk assessment to be performed based on your clinical judgment. So blood pressures are not indicated until 3 years of age, which I know many of you know. So what does the AP say about people, or little children, who are less than 3? These, it's just what I said, the risk assessment should be performed with appropriate action to follow. What does that mean? Let's go into the people that you should be checking who are less than 3 years. So those guidelines come from this task force. The most recent ones are in 2004, and that's the 4th report, or which I will refer to for the remainder of the talk as the 4th task force guidelines. And this is the diagnosis, evaluation, and treatment of high blood pressure in children and adolescents. This report is free, and it's open on Google. I love Google. You just go to google.com and you put blood pressure, children, and it goes straight to this link. It's the first link. So if you're in your office and you're wondering, I have a 5-year-old, I have a 1-year-old, what is a normal blood pressure for this child? Should I be worried? And they're calm, you can always go to this link. It's the first one. So their recommendations for the 4th task force in children less than 3 years: history of prematurity, history of low birth weight, congenital heart disease, either that's repaired or non-repaired, including that PDA in our infant who got indomethacin, recurrent UTIs, proteinuria, hematuria, as well as renal urologic disease processes, anyone with a history of congenital renal disease in their families, bone marrow transplant or any solid organ transplants, treatment with known hypertensive medications, either in the NICU or from another practice before coming to yours, neurofibromatosis, tuberous sclerosis, or any history of increased intracranial pressure. So I'm going to first talk to you about hypertension in NICU graduates. The incidence is actually quite low. The first study came out in 1987 by Friedman in Madison, Wisconsin. And he was getting numbers like 2.6% in all the babies that they had seen in a 3-year follow-up period. So it's kind of small. Singh did this again in 1992, and then most recently there was an international study in Australia by Celium in 2007. So the range is quite small, as I mentioned, 0.8 to 3%. But again, the true incidence of hypertension in these high-risk infant is unknown, because these populations were all NICU infants. You came in for hypoglycemia, you came in for any reason, meconium aspiration. It's not really looking at all those high-risk infants. So what are the conditions that you might see associated with hypertension in these NICU graduates? One of the big studies that came out occurred in 1984, and this is by Abman in Pediatrics. This is one of the studies that we all look to when we have consultations in our pediatric nephrology practice. And what they found is that in the incidence of hypertension, 43% of those babies had chronic lung disease. And only 5%, close to 5%, did not have chronic lung disease. The most interesting thing that I want to drive home is that half of these infants with chronic lung disease developed this hypertension after they were out of the NICU with a mean estimated age about 2 months. So that might be the time that they're coming to see you. So they're normotensive during their stay, and then they go and they come to their pediatrician. Now this was only reproduced one time in 1998 by Agapan in the Journal of Perinatology. The other conditions you might see, in addition to chronic lung disease, is indwelling umbilical catheters. This was first reported by Neal in 1972, and what they had found is 81% of children who had umbilical arterial catheters developed renal arterial thrombi. With all the techniques that we have now, that number is about 25 to 30%. So still, you have a quarter of kids who get umbilical lines like that UAC. They still have a risk for arterial thrombi. They still have a risk to develop hypertension just by having a catheter. Now, 8% of those infants may develop hypertension. Renovascular disease always puts you at risk for hypertension. A PDA, just like our patient. Intraventricular hemorrhage, AKI. Exposure to antenatal steroids, maternal hypertension, and of course, any anomalies of the kidney, cystic kidney disease, or anomalies of the whole GU tract. So back to our clinical scenario. Should we assess a BP in this patient? Let's go through some of the risk factors that I had mentioned that may be pertinent to this patient. Low birth weight, 700 grams. Born premature to maternal preeclampsia. She has antenatal steroids. She has that UAC. And now chronic lung disease. It took a while for her to get off that oxygen. and she also received indomethacin. All these risk factors that you see here are not uncommon to the patients that we do get consulted from your practices as well as from inpatient at Children's. This is actually just a little bit of all the things that we see. So now you need to take a blood pressure. You've decided this is a baby who was in the NICU, normotensive in the NICU, you know, ring, 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 I need to take a blood pressure, what should I do? Now the tips for obtaining accurate blood pressures. Now I realize some of these are just gonna seem absurd when you have a busy practice and there's a crying baby, but I'm just gonna review with you what are the optimal settings. These were published in 1997 in Pediatrics by Nguyenko et al. The optimal time is 1.5 hours after a feed. In that study, they had looked at blood pressures 1 hour after feed and 1.5 hours. Now that's kind of hard when you have a newborn who's, you know, feeding every 1 to 1.5 hours, especially if it's breastfeeding. So we understand that. Optimally, when the infant is calm, and I think we all want that, place the cuff and allow for acclimation. What I like to do when they come to our practice is, since a lot of the studies have shown that the first blood pressure you take is always going to be higher than the subsequent pressures, I just put the cuff on so at least they get used to it, go around, get my history. You know, for us, we look at the urine, if there is any, and then I come back and check that pressure. You want to put in the right upper arm. Now this is crucial. We see in our NICU as well, in our ICUs, we get consults all the time for high blood pressure. It's always in the lower extremity. The lower extremity is always higher than the upper extremity. So I do caution you to use that right upper extremity because all the guidelines are based in the upper extremity. So that's important because you don't want to treat someone who may have a normal blood pressure but may look high to you when you first see it in the lower extremity. And position does matter, and this is a typo in your syllabus. The supine is higher than prone position, so if you could just turn that upside down. And of course, you want to use the appropriately sized cuff. So now you've decided, I'm going to check a blood pressure. How do I do that? Let's pretend you have the optimal settings for this little baby who just came to your office. So choosing the correct cuff is important. So obviously, this is much bigger than what you'd see in a newborn infant. Most of the ones that we use are from Criticon for Dynamap, and all the blood pressure norms in newborn babies are based on those Dynamap pressures. So we try to do manuals as much as we can on the babies, but I realized, and I want you to know that all those are done on Dynamap. So this is what we're talking about when we look at the width. This part here, you want to wrap this around the baby's arm, and that should be about 40%. And then the length, of course, from your elbow to your shoulder should be about 75 to 80%. Try to do those surveys after the talk. Now, there's a variety of blood pressure cuffs. There's a tempo cuff I appreciate as well because you don't have to do all this measuring. You can just look at the baby's arm. You can, you know, if you're doing a circumference anyway with your head circumference and your length of the baby, that actually tells you the range here. And you can decide if you have the 1, little baby 1 to the 5 as they get older. But you want to use the right upper extremity just as it's shown right here. So now we know, we decide to take a blood pressure, we know how to check one. What do I do with the number? So let's pretend that the baby that we saw, that 12-week-old who's corrected to 41 weeks, let's give her, I don't know, 110 over 70. Do you think that's high or low? Just a guess. Okay. So normal blood pressures correlate to the less than 90% curve established for age for these babies. Now in older children, and I'll talk to you about those in a little bit too, gender and height are also factors in this consideration. So the established newborn curves are based by work by Zubrow et al. In 1995, and we're still using those curves today throughout the US in pediatric nephrology practice. The data is acquired from 608 infants, 9,000 infant records. These were all done on Dynamap with 24,000 assessments. They looked at 14 NICUs in the Philadelphia area. So there are 2 nurse practitioners who taught each nurse in a NICU how to take the pressure in a right upper arm. It was before a feed. Some looked at the after a feed. They did it every 8 hours from days 1 to 99 of life. And this is the biggest consortium of data that we have. So what you can see here is, let's put our patient in this. Where would she be? So at 41 weeks, you can see that the 50th percentile, when you're looking on the left graph of systolic blood pressure as a function of how big this baby is in terms of post-conceptional age, is about 80. Sorry, I was looking for the little arrow. And then on the right, when you're looking at the diastolic blood pressure as a function of post-conceptual age, you see that it's about 45. So 80 over 40, 45 is normal for this baby. That's just on the solid line. When you look at the confidence interval, those are the dashed lines that you can see there. So based on the Zurau curves of a 41-week-old corrected infant, our baby does have hypertension. And also from your own gut, you knew that was too high. But now you can see where it comes from. So what about the babies who are 0 to 12 months age? You have a 6-month-old. Let's pick our 6-month-old who now just comes to you from another practice. You heard they were from they had been in a NICU, same kind of story, but now this is the first time you're seeing them. Should you check a blood pressure in them too? I would say yes, especially if you know that they'd been in a NICU. This is your first assessment of this baby. Now you want to look again at the 90th percentile. So on the left are the systolic and diastolic pressure curves for boys, and on the right are the girls. So for a 6-month-old, when you're looking at the boys, it's going to be about 106 over 66. So less than 106 over 66 is okay for a 6-month-old. And then you can see how it changes, that as you get bigger, you're allowed to have a little bit more blood pressure. Now what about if this child is 2 years old and shows up to you? Should you even check a blood pressure? And I'm asking you this because we know Bright Futures says you don't need to till 3. But now you have all this information about this baby, and they moved from a different state, and now they're in your practice. Should you wait till 3 to check their blood pressure? I would still say no, because now you know they were NICU, they had all this stuff. If someone else hasn't checked it, you should still check it. So the 90th percentile, when you look at this, now this comes from the National 4th Task Force guidelines, the ones I told you. If you just go to Google and you say blood pressure children, it's the first link that pops up. So it's a huge PDF, but it usually directs you right where you want to go, boys or girls, and those are age 1 through 18. So what you do is you go to the 2-year-old here, and then you say 90th percentile, and I just put a little highlight around it. And if this child is 5th percentile for height, so you look in that first column, 97 is going to be normal for systolic, and then 54. So you basically will look at this child and say, okay, less than 97 or 54 is okay. I don't have to do anything. So what should your initial diagnostic evaluation be? Now you know where we find our established curves from a baby who is just born to someone who's 18. So you want to do serum chemistries. Obviously, I like to look at BUN and creatinine. I do that a lot. But you want to also look at the electrolytes, and that's important for some very rare causes of hypertension. So it's important to see what the potassium and the sodium is. You want to do a CBC and evaluate for anemia, because as you know, erythropoietin is made in the kidney. So if there's any indication of chronic kidney damage in these babies that are coming out to you, then you'll be able to see that as well in their iron stores. You want to consider an echo, looking for coarct as well as left ventricular hypertrophy, a renal ultrasound with Doppler, and there you're evaluating for renal blood flow and hydronephrosis, as well as how big the kidneys are. And usually when babies are full term, 4 centimeters is how big the kidneys usually are. And some of the work that was done on saying what is a normal size for a kidney was all done at Children's, where they ultrasounded in the 80s all these normal kids, and we actually can see how big that kidney should be. And urinalysis, you want to look for proteinuria and hematuria. So here, I'm just giving you a list of approved blood pressure medications that you may see your patients either be on coming out of a NICU or see a consultant put them on. Captopril is the most studied in NICU babies. Usually the indication is we try to wait till 44 weeks. There's different people in our field that decide whether or not it's safe to use it or not. We do use it at Children's for NICU babies. Isradipine is new to our formulary. It's basically a fancier, souped-up amlodipine. Propranolol, clonidine, we don't like to use that one that much, and minoxidil, which is a very potent vasodilator. When you're at this point and you see these blood pressures above the 99th percentile, that may be a good time to get a consultation, and we'd be happy to talk to you about that. So what are some take-home points? So you want to consider blood pressure assessments in babies with low birth weight and prematurity, NICU graduates, all those that I had mentioned, those especially with heart disease, BPD or chronic lung disease, and umbilical lines. UACs have more of a risk than UVCs, but I put umbilical lines in general here. Abnormal renal imaging. And to get the optimal assessment, you want to get 1.5 hours after a feed. Again, I realize that is not always going to happen. And measurement in the right arm. You want to use the appropriate BP reference when you're saying, is this person hypertensive or not? So Zubrow curves in the neonatal period, the second task force guidelines from 0 to 12. And then you want to continue to monitor these kids. Because we actually, and I myself in the 3 years of fellowship have seen many babies who, they're 5 or 10 years old, and the parents tell me, oh, they were a history of prematurity, and nobody checked a blood pressure, and by the time they're actually checked, they're like 150 over something. And we do a DMSA, we see scarring in the kidneys. So it's an easy thing to do if you have a chance to just check a blood pressure, and we would be happy to see them sooner in our program. So with those older kids, you want to use the forced task force guidelines, and you want to consider referral to specialists when they're greater than 95 percentile. And between the 95 to 99th is when we start deciding which medication to use. Thank you so much.